A Patient's Guide to Prostate Cancer. What to know about the disease's causes, complications, treatments and more. In 2019 alone, nearly 175,000 American men will be diagnosed with prostate cancer, the American Cancer Society estimates. About 1 in 9 will be diagnosed in his lifetime, and about 1 in 41 will die of the disease. That makes prostate cancer the most common cancer in American men outside of skin cancer, and the second most common cause of cancer death after lung cancer. The good news is that prostate cancer is treatable, and in many men, the cancer is slow-growing enough that they can live full, healthy lives without treatment at all. Signs and symptoms. It's almost impossible to feel like you might have prostate cancer. The tumor typically grows without causing pain, discomfort or visible changes. Rather, most men discover they may have the disease after undergoing screening. However, later-stage disease may spread to nearby tissues and lead to prostate cancer. Signs and symptoms, including frequent and/or urgent urination, uncontrolled urination, painful urination, erectile dysfunction, painful ejaculation, less semen produced during ejaculation, blood in urine or semen, rectal pain or pressure, hip, pelvis, or lower back pain or stiffness. If you experience any of these warning signs, see a doctor. It's very likely you do not have prostate cancer, but urinary, rectal and sexual problems shouldn't be ignored, no matter what the cause. Age. Prostate cancer risk increases with age. Most men are diagnosed at or after age 65, and few are diagnosed before turning 40. The average age of a prostate cancer diagnosis is about 66, per the American Cancer Society. Rather than study prostate cancer survival rates by age, medical organizations tend to classify survival rates by stage. Statistically speaking, men with local stage prostate cancer, meaning the disease seems to be contained in the prostate, have a relative 5-year survival rate of nearly 100%. Men with regional stage prostate cancer, meaning it spread to nearby areas, also have a near 100% relative 5-year survival rate. Men with distant stage prostate cancer, or cancer that has spread to lymph nodes, bones or other organs, have a relative 5-year survival rate of nearly 30%, according to the American Cancer Society. All of these numbers, however, are general statistics and don't tell individual men how long they are likely to survive. Plus, because treatments continue to advance, how men who are diagnosed today fare is likely better than the men whose data comprise these statistics, since they were treated years ago. Our techniques and technologies for treating prostate cancer have changed over the years to include less invasive surgical options and various forms of radiation therapy, says Dr. Bobby Liao, the Clinical and Medical Director of Genitourinary Oncology for the Mount Sinai Health System in New York. Causes. No one knows exactly what causes prostate cancer. Like many diseases, it's likely some combination of environmental and genetic factors. For instance, inherited genetic mutations in BRCA1 and BRCA2 genes have been linked with an increased risk of certain cancers, including prostate. A lot of it comes down to genetic mutations that people inherit from their parents, Liao says. Still, no more than 10% of prostate cancer cases seem to be directly due to inherited genetic mutations, according to the Prostate Cancer Foundation. Put another way, as the ACS notes, most men who get prostate cancer don't have a family history of it. One thing that's definitely not a cause of prostate cancer? A lack of sexual activity. In general, prostate cancer develops when a normal prostate cell starts to grow abnormally, something that has nothing to do with your sex life. And while some sexually transmitted diseases are being studied for their connection to cancer, no conclusions have been reached. Prevention. Until researchers know more about the disease's causes, doctors won't be able to prescribe any surefire ways to prevent prostate cancer. However, doing what you can to support good health overall may help. For instance, eating fewer animal products, especially red meat and high-fat dairy, and more fruits and vegetables seems to be associated with a slightly lower risk of prostate cancer, according to the American Cancer Society. We don't really have a lot of fantastic strategies for preventing prostate cancer. That's a little bit because we can't isolate any inciting event for why cancer comes about, Liao says. And this isn't just prostate cancer, it's hard to pinpoint exactly where any cancer comes from. Risk factors. While researchers don't know the exact causes of prostate cancer, they do know that certain populations are more likely to develop it. You may have a greater risk for prostate cancer if you are 65 years old or older, have a father or brother with prostate cancer, have multiple relatives who've had prostate cancer, especially if any of them were diagnosed at a young age, have a family history of other cancers, like breast cancer, ovarian cancer or pancreatic cancer, are of African or Caribbean ancestry, have Lynch syndrome, a condition caused by inherited gene changes, complications, later stage prostate cancer, and prostate cancer treatments including surgery and radiation can lead to a variety of side effects and complications. For instance, the disease itself can lead to urinary, bowel and erectile dysfunction. Complications from a prostatectomy, a surgery to remove part or all of the prostate gland, may include urinary or stool incontinence or impotence, although modern nerve-sparing surgeries have reduced impotence rates. Complications from radiation can be similar, and it's unclear whether one treatment is less likely than the other to lead to such side effects. Infertility is near inevitable after prostate cancer surgery and very likely after radiation. You may be encouraged to bank your sperm if you'd like the option of having children after your treatment. Screening and diagnosis. If or when you begin prostate cancer screening and how often you do it is largely a personal decision that should be part of an ongoing discussion with your doctor that takes into account your personal risk factors and understanding of the pros and cons of screenings. Men ages 55 to 69 should talk to their doctors about the pros and cons of screening based on their personal risk factors and decide for themselves when and how often, if ever, to undergo it, the U.S. Preventive Services Task Force recommends. The task force recommends against men 70 and older getting screened since by that age, the risks of screening, like subsequent unnecessary treatments, typically outweigh the benefits. If you have risk factors for prostate cancer, however, don't wait until you're 55 to have a discussion about screening with your doctor. Per the American Cancer Society, such conversations should begin at age 45 if you're at high risk. For African American men and those with a first-degree relative, such as a father, brother or son who was diagnosed with the disease before 65, and at age 40 for men with higher risk, men with multiple first-degree relatives who had prostate cancer at a young age. The Act suggests that even men with average risk should discuss screening at age 50. PSA test and Gleason scale. Doctors typically screen for prostate cancer by using a digital rectal exam or when he or she inserts a gloved finger into the rectum to check for irregularities, and a PSA prostate-specific antigen test, a blood test that detects higher than normal levels of PSA, which may indicate prostate cancer. Because what's a normal level of PSA is different for every man, the PSA test is just one way to monitor how likely it is you have prostate cancer, but is not the be-all and end-all diagnostic tool. That said, if your PSA levels are above a 3 or 4, your doctor may recommend a biopsy to get more information. If you do undergo a biopsy, a clinician may identify a Gleason score between 2 and 10 that helps classify how aggressive or not the tumor cells are. Generally, a lower score means less aggressive and a higher score means more aggressive. But even tumors categorized on the more aggressive side per the Gleason scale aren't necessarily especially risky, so doctors may also use another system developed by the International Society of Urological Pathologists called the ISUP grade groups, which ranks riskiness into 5 groups. Treatment. Prostate cancer treatment generally falls into 3 categories: watchful waiting, surgery or radiation. The big question is to treat or not to treat, says Dr. Philip Kantoff, a medical oncologist and prostate cancer researcher who serves as chair of the Department of Medicine at New York City's Memorial Sloan Kettering Cancer Center. Because prostate cancer can be very slow-growing, men may opt to simply monitor it with their doctors, especially if they're older than 60 and could be more likely to die of old age than of any complications from prostate cancer. Men who do decide to treat the disease will typically be given the choice between surgery or radiation, or sometimes a combination of both. Because there are no clinical trials comparing their ability to prevent the spread of cancer, and one isn't clearly better than the other, the decision typically comes down to personal preference. Do you hate the idea of surgery, or hate the idea of making a treatment more drawn out? And provider. It depends on the patient's interpretation of side effects, it depends on who the patient sees, it depends on the advice they get, Kantoff says. Prostate cancer is the most common cancer found in men. However, when it's caught and treated early, the cure rate is high. After treatment, most men will be able to live cancer-free for years, if not for the rest of their lives. In fact, the 5-year survival rate for men with localized prostate cancer is nearly 100%. That said, it's still possible to have a recurrence of the cancer, and between 5 to 40% of men will experience this. Cancer recurrence is the return of cancer after a period when no cancer cells are detected in the body. Not all recurrences are the same, and not all will require active treatment. Because the risk is present, it's important to be aware of the possibility and know what you can do to lower your risk, plus be knowledgeable about how to proceed in the event it does recur. See what only your partner knows about your health. Recurrence of prostate cancer is mostly related to the stage and degree of aggressiveness of the cancer at the time of initial treatment. The higher the stage and the more aggressive the cancer cells at time of treatment, the greater the chance of treatment failure or recurrence of the cancer. There are 2 ways in which the prostate cancer can return and be detected. The first involves the development of symptoms of recurrence such as leg edema, blood in the urine, progressive fatigue, bone pain and back pain. The second is referred to as a biochemical recurrence, and it involves a rise in the man's PSA prostate-specific antigen levels. After treatment for prostate cancer, PSA levels should drop significantly, to undetectable levels post-surgery, and to levels below 0.5 nanograms per milliliter after radiation therapy. If some time after treatment there's a consistent rise in the PSA, this indicates that some of the cancer cells have survived and are still making PSA. It should also be noted that PSA may fluctuate for 2 years after radiation, but not after surgery, for prostate cancer. The important thing about this type of recurrence is to confirm a constant rise. Stable, low PSA levels that don't steadily rise post-treatment may be fine and not necessitate treatment. When monitoring recurrence with PSA levels, a rise doesn't always require immediate action. The rise in these numbers will occur well before any clinical signs or symptoms manifest themselves. Because the cancer is so slow growing, some people won't show symptoms for years. However, if a steady rise is identified, this indicates either the cancer has recurred in the area where the prostate used to reside, local recurrence, or it may indicate the cancer has spread metastatic. There are a number scans, blood tests and parameters that are checked to determine presence of local recurrence versus metastatic development. See 10 lessons from empowered patients. In cases of local recurrence, there are additional therapies that can be provided with the intention of curing the prostate cancer. The second round of treatment largely depends on where the cancer is located and what treatments have already been done. For a man that has had the prostate removed, radical prostatectomy, radiation therapy sometimes combined with hormone therapy may be the next course of action. If the first treatment was radiation, other options, including cryotherapy, high-intensity focal ultrasound or robotic, open salvage prostatectomy, may be considered. In cases of metastatic prostate cancer, there are hormone therapies that slow the growth or advancement of the cancer. Keeping in mind a risk-benefit analysis will help the doctor and patient make the treatment choice that yields the highest chance for cure with the least amount of side effects. Despite the predestined nature of cancer for many people, there are some correlations with lifestyle that allow men to play a part in their prognosis. Obesity and other health conditions, like metabolic syndrome, have been shown to increase the chances of prostate cancer returning after treatment. In one study of patients who were followed for 4 years, prostate cancer returned in 32% of obese patients, as opposed to only 17% of those who were not obese. In addition, patients with metabolic syndrome had a 4 times higher risk of cancer return than those without the syndrome. Metabolic syndrome includes a group of adverse conditions such as high blood sugar, high blood pressure, obesity and high cholesterol levels. The bad news is that obesity and metabolic syndrome have become increasingly widespread in our country due to lack of exercise and poor eating habits. But the good news is that with some lifestyle modifications, like eating a well-balanced diet, exercising regularly, reducing stress and getting enough sleep, these conditions can be avoided and the risk for prostate cancer recurrence lowered. The entire risk cannot be eliminated, but it should be encouraging to know that every man can at least take some action to help. See 10 things younger men should know about prostate cancer. Doctors don't fully understand why cancer recurs in some men and not others, so living a healthy lifestyle to avoid the risk you can, keeping up with doctor visits after your initial treatment and being aware that the risk does exist are the best things you can do to keep your prostate health in check for life. For 2 decades, prostate cancer deaths had been steadily declining. In 1993, about 39 in every 1,000 American men died from the cancer that starts in the walnut-sized gland between the bladder and the penis. Often that's where the cancer stops, but in some men it progresses and can be life-threatening. With advances in treatment, though, the death toll was halved to under 20 per 1,000 by 2012. But, in 2013, we noticed that the slope or the speed with which this rate of prostate cancer mortality declined in the past, kind of changed, says Dr. Serban Nagoita, chief of the U.S. National Cancer Institute's Data Quality, Analysis and Interpretation Branch. Nagoita is the lead author of the prostate cancer section for the annual report to the nation on the status of cancer released last month. That report found that age-adjusted prostate cancer death rates leveled off, and were all around 19 per 100,000 for the most recent years captured, he says. Rates still declined from 19.56 in 2012 to 19.26 in 2013, 19.1 in 2014 and 18.92 in 2015, but the decrease wasn't statistically significant. What's more, even as the overall incidence of prostate cancer continues to decline, the rate of late-stage disease increased between 2010 and 2014, according to the Status of Cancer report. More men, about 8 per 100,000 based on the latest, 2014 figures, compared with around 6 in 100,000 in 2010, are being diagnosed with so-called distant cancer, or disease that's spread from the prostate to other parts of the body like bone, lungs and brain. See 10 things younger men should know about prostate cancer. In the past, screening for prostate cancer with a prostate-specific antigen, or PSA, test, was more roundly recommended and treatment essentially automatic following a cancer diagnosis. But in more recent years, evidence of harms associated with overdiagnosis or overtreatment has led to a more conservative approach. Experts note that because of the typically slow-growing nature of prostate cancer, more men die with the disease than from it, and they point out many men have been exposed to harms and side effects, like incontinence and impotence, of unnecessary treatment for prostate cancer. But as debate continues to swirl around prostate cancer screening, some experts have raised concerns that these latest trends show not enough is being done to protect men from this top cancer killer. In regards to the potential benefits of screening, there is still a huge question mark, says Dr. Otis Brawley, Chief Medical and Scientific Officer for the American Cancer Society. I think most of us tend to believe that there is a small benefit to prostate cancer screening. The clinical trials suggest for every 1,000 men screened over a period of time, instead of 5 dying from prostate cancer, 4 will die from prostate cancer. But a goodly number, several dozen, will be needlessly diagnosed and treated. Based on the latest evidence on screening, the U.S. Preventive Services Task Force recently changed its recommendation on prostate cancer screening to suggest, like the ACS and other groups do, that screening should be an individual decision made by a man in consultation with his physician. We're recommending that men age 55 to 69 who are considering prostate screening talk with their doctor about the benefits and harms of screening, and they decide whether screening is right for them, says Dr. Alex Christ, Vice Chairperson for the USPSTF, and a Professor of Family Medicine and Population Health at Virginia Commonwealth University. That took the place of its controversial 2012 recommendation against men getting a PSA to screen for prostate cancer. The USPSTF still recommends against a PSA for men 70 and older. We made that change because we got more evidence and more follow-up from the trials from 2012 to now, Christ says. That provided a longer view of the impact of prostate cancer screening and, where necessary, subsequent treatment following detection. With longer follow-up from European research, we observed that a few more men won't die from prostate cancer, so it increased from 1.07 to 1.28 per 1,000, which doesn't sound very big, and it's not, but it gave us more confidence that over a great length of time more men might not die from prostate cancer. The Status of Cancer report notes that the use of PSA testing substantially decreased following the USPSTF recommendations against routine testing for men aged 75 and older in 2008 and for all ages in 2012, and it suggests this may have contributed to the less rapid decline in prostate cancer death rates during the most recent years compared with the previous period. But Ngoita is careful to point out that the Status of Cancer report didn't evaluate the reasons for the changing prostate cancer trends. When there was the change in 2012 from the U.S. Preventive Services Task Force to recommend against PSA screening, we saw screening numbers go down, adds Karen Knudsen, enterprise director of the Sidney Kimmel Cancer Center at Jefferson, based in Philadelphia. We also started to see more men present with advanced disease. And so while I cannot tell you for certain that these are related, certainly one followed the other. Others say it's too early to tell if or how screening recommendations could have impacted prostate cancer deaths or late-stage disease rates. Christ emphasizes it's not clear what's driven the latest prostate cancer trends. See, the scary side effects of testosterone replacement therapy. Experts say a positive that's come from more circumspection surrounding prostate cancer screening and treatment is that there seems to be more space in the conversation today for watchful waiting when a man is diagnosed with prostate cancer. That is to say, there's more dialogue around simply monitoring some prostate cancer closely, not necessarily treating it, where appropriate. It used to be said that American men could never be persuaded to have no treatment for cancer. American men, they have a problem, they like to fix it, says Dr. Anthony Zietman, a professor of radiation oncology at Harvard Medical School. That was completely false. It was the physicians who couldn't be persuaded to not treat men with cancer. But that's changing, he and others say. In 2012, most men with low-grade prostate cancers were getting surgeries or radiation, what we call active treatment, and that leads to more harms, like the incontinence or impotence, Christ says. Now about 40% of men, instead of just 10%, are getting what we call active surveillance, which might delay surgery or radiation, or even prevent it. And that can reduce the harms as well. Brawley says more than half of men diagnosed with localized prostate cancer, where the disease is only in the prostate when detected, are now being watched. Most of those men will never be treated, he says. Watchful waiting is starting to catch on. That's an important middle ground, clinicians say, as men try to cut through the noise that can make deciding what to do about the threat of prostate cancer a head-spinning affair. I think in the past we were overaggressive in our screening. But screening wasn't really the problem, Zietman says. It was treatment that was the problem. We were overaggressive in our treatment. To drill down further in making an individual decision, experts say it's important to consider one's family history. African American men and guys with a first-degree relative, father, brother or son, who's been diagnosed with prostate cancer before the age of 65 are considered to be at high risk of developing cancer, and they should talk with a health provider about the uncertainties, risk and potential benefits of screening starting at age 45, the ACS recommends. Those at even higher risk, with more than one first-degree relative who had prostate cancer, should begin that discussion at age 40. The ACS recommends men of average risk begin the conversation about prostate cancer screening at age 50. If a man has a strong family history of not just prostate cancer, but breast cancer, ovarian cancer or pancreatic cancer, we know that we should look very carefully at that particular man's family for prostate cancer risk, and he may be a candidate for genetic screening, Knudsen says. Some of the same genetic alterations that give risk for breast, ovarian and pancreatic cancer also confer risk to prostate cancer. The USPSTF notes in their latest recommendation on prostate cancer screening that evidence is insufficient regarding whether genetic or adjunctive imaging tests meaningfully changes the potential benefits and harms of screening. This is an important area of current research that has the potential to decrease the harms of PSA-based screening for prostate cancer. See 13 Ways Social Determinants Affect Health. A key is that men receive the information they need and aren't made to feel like they should, or should not, get screened for prostate cancer, experts say. A man who doesn't want to be screened should not be criticized for that. And a man who does want to be screened should not be criticized for that. They should be supported in their decisions, Brawley says. And if a man is diagnosed with prostate cancer, what he does next, including whether to treat it and if so, how, shouldn't be a foregone conclusion either. It's not about having prostate cancer, it's do you have the kind of prostate cancer that needs treatment? So I think screening is okay so long as patients realize that if they are diagnosed with prostate cancer, that doesn't inevitably mean treatment, Zietman adds. It means time to slow down and be thoughtful and make an informed decision. Thank you for watching. Please hit the like button and subscribe for more latest videos.